why don't we turn our business today to our wonderful presenters. I'd first like to introduce myself for those of you that don't know me. I'm Suzanne Maselli. I'm the Associate Dean for Development at the BU School of Medicine. And it is wonderful to see all of your faces. I'm so glad that you're all staying safe and healthy. And I'd like to thank all of you on behalf of all of us for your generous support and your steadfast commitment to the BU School of Medicine, now more than ever. You are our most generous supporters and our friends, and we really appreciate your support. I'd also like to just cover a little bit of housekeeping. All participants will remain muted for the duration of the webinar. You can enter a question at any time using the chat function at the bottom of the screen. We've already received a few questions, and we will address those and any that you submit after we hear from our two presenters. And if there are any questions that we don't get to, we'll respond to you after the webinar. This webinar is being recorded. We have with us today Dean Karen Antman, our provost for the BU Medical Campus and Dean of the School of Medicine. We also have with us Dr. John Polk, who's an alumnus, class of '74. He's our Associate Dean for Diversity and Inclusion, and he's also instructor of surgery. Dr. Antman will provide you with an update on the status of the school, our back to school protocols for safety, followed by Dr. John Polk's presentation on racism and how the campus and the community are addressing the issues that we're all finding so very painful today. So I will now turn over the screen to Dr. Antman. Thank you, everyone.
It's terrific to see all of you. It's really remarkable how good Zoom is. We're all getting to be incredible experts at it because we're doing all of our classrooms and meetings with it, but it actually has some real advantages. The students are actually up closer and you can see their body language in a way that you can in the classroom. So it has some advantages and disadvantages. I'd like to share my screen. Let's just see how this is. Host disabled screen sharing. So you managed to, let's see if you can get me back up again, that would be good. If you click on me, we should be able to make me, let's see, because I had it up.
Just give me 1 second.
Okay.
I just made you the co-host, if you could try it again, maybe.
Host disabled attendee screen share. I'm an attendee, I guess.
Okay, you should try again.
Okay, we got it. I think we got it. Share. And use slideshow, and we should be good to go. Good, okay. So it's a real pleasure to be bringing you up to date. I think that the picture shows everything that's happening on campus. You've got people socially distanced. Most of them are wearing masks. Actually, I think almost all of them are, that you can see. And we've had quite a bit of activity with demonstrations on campus and off, and certainly our students, faculty, and staff have all been involved. So I'd like to title this presentation, the BUSM Campus Update, Anything But Normal. And you'll see why in a second. Just a couple of things that the last time that the Dean's Advisory Board got together and many of our alums, we talked a lot about student debt. So I wanted to tell you about our graduating class of 2020. You can see that we were very careful about debt for the last 3 or 4, well, we were careful before that, but we had been increasing in debt by maybe 3% per year, 16, 17, and 18. But we then said we can't just keep doing this. And we put some additional funds, operating funds, into scholarships. And you can see that the class of 19 graduated with a lower debt than the class of 18. And our class this year graduated with a debt that was slightly lower than last year's. So at least we're holding, and if not making some progress on this. That did mean that we took about $7 million of endowments on operating funds and increased the scholarships that we could provide for our students. Doctors Wheelock and Ragland, I didn't see Wheelock on the group yet so far, but I did see Dr. Ragland asked about the demographics. So I have a couple of slides. One is our incoming class and then what we've been doing all along. You can see that this is our incoming class that's starting next Monday. We have, you'll see the numbers on the left side, the percentages on the right. We have a total of 26 26% underrepresented minorities. Actually, whites are 38% of the class, so this is a majority minority class. We have substantial numbers of Asians. Dr. Wheelock specifically asked about evidence of discriminating against Asians, and I think that number shows that Asians compete very well for our classes. And I'd be happy to answer any questions about that. I can't see you if you raise your hand, so you're going to have to do something in the chat box so that the people in development notice it and interrupt me. You can see this is the kinds of data that we get from the AAMC, and they give us versus other medical schools. You can see that we're above the 85th percentile on the number of graduates, and this is between 2013 and 2018. So we've graduated about 85th percentile of other medical schools for Latinx students. We're down about 5.8%, but above the median, which is not where we'd want to be. We'd want to be much more for Black or African Americans. You can see we don't do very well with Native Americans, but I think that's okay because we're competing with states like Arizona and where there are many, many more tribes. We do reasonably well with Native Hawaiian Pacific Islanders. We have a pipeline program with Hawaii, so we get a fair number of students. You can see that we also do reasonably well with the percentage of faculty who are women. So we're going from students to graduates over here to faculty to the right. We're at about the 99th percentile for percent of women faculty, and we're at about the 75th percentile for Latinx faculty, and about the 9th percent, but above the 50th percent for about the 55th percent for African American faculty through 2018. That's the last comparative data that we get. So this is this year's data looking at us versus other medical schools. We'll get 2019 next year, so they're always a year or two back because we're comparing us with other people. COVID hit Massachusetts very hard, but not as hard as New York. You can see that we're significantly higher, however, than US deaths, at least through the months of April and May. That may change as the US deaths are now going up. I pulled this off the web yesterday, so you can see it's up-to-date data. We basically had many of our events throughout the epidemic. We planned our virtual medical school over a very short interval. Starting in March, we were out on the March 15th was the last day on campus. 5 days later, we had match day. Graduates for the MD program graduated a month earlier than usual in April. And our PhD graduates, sorry, that was a mistake, graduated May 17th, along with the rest of the university. By that time, the number of deaths in Massachusetts were coming down. We are welcoming our new class next Monday for MDs and our new master's and PhD students on September 2nd. We're worried because the COVID cases in Massachusetts have leveled off, and if anything, might be tipping up a bit. So we had a 3-week period to learn video teaching from home. Everybody did it. The educators designed new courses so that students would have courses on disaster management, COVID, telemedicine. We closed up all of the buildings and put them on card access. You could still get in, but you had to go through card access. The hospital had at one point up to 70% COVID patients. Newton Pavilion became a field hospital, as well as the convention center downtown. The FDA approved an in-house COVID testing center for the hospital because we couldn't get tests back from anybody in real time. So we basically, our PhDs put together the COVID testing center and got the materials, and we actually tested for our patients for 2 or 3 months until we could get commercial vendors. And otherwise, only essential research was happening, cancer treatments that people needed and COVID research, for example. The needle became 100% COVID. They decided that because we needed PPE for our clinical colleagues, they would do all COVID research in level 4 rather than level 3, where they would require PPE and therefore compete. We have published about 120 papers since March on COVID. That's remarkable, by the way. We normally can't get papers out with that kind of speed, and it's maybe another 10 or 15 papers per week going out on COVID implications. The students had their new courses, and they were very reasonable and certainly understood the situation. 500 of them became volunteers. That's 500 out of the 700 total. They provided childcare for our staff, delivered meals, traced COVID contacts, called up follow-up patients. They worked, some of them, although we were pulling them out of the clinics, not knowingly signed up for the field hospitals where there were COVID patients. That's their prerogative to do. Certainly pregnant patients weren't getting blood pressures, and so they distributed blood pressure cuffs to pregnant patients and PPE to homeless shelters. But they were really doing a remarkable job. Our communications office put out this, you hopefully have all seen it, came out about 2 weeks ago. It's The Heroes Among Us, and it has some really great stories about our faculty and staff and students. Pediatricians turned around and were caring for seniors. Orthopedic surgeons and deans were screening patients out in the tents. Providers were living in their basements or dorms to avoid infecting their families. And there's some really good stories in that. So I hope that you've had a chance to peruse it. We did keep the academic functions continuing. Faculty appointments and promotions met on Zoom every month, and the faculty appointments went right up to the Charles River campus and came back approved. We had a lot of committee retreats and planning because we could. And in fact, attendance was even better than usual. It's because nobody was at meetings somewhere else. We had town meetings for the faculty, students, and staff, and the admission cycles went on. The applications for the MD program were about the same as last year. The master's program, we did more accepts because we were worried that fewer of them would come. We're up about 6% at present, but you're never always sure who's going to show up. And we won't really know for master's and PhD programs until September. But we did put up we're certainly not hurting on mutual accepts, at least at this point, but we're tracking them very carefully, as is the undergraduate campus. So status as of like tomorrow or Saturday, the field hospitals both closed in Boston, but they're staying ready to go because the state's afraid that they might have to open them up again. We narrowly avoided crisis standards of care, which is where you begin rationing. Nobody wanted to go there. We did have one situation where we had to transfer patients to other hospitals because we ran out of respirators of our own, but fortunately there were other hospitals still had a couple. But we came very, very close to actually filling up all of our beds and all of our respirators. The research Oh, I should also make one point. We actually changed, the lawyers for BMC went and changed the crisis standards of care because we realized that it discriminated against our patients. Our patients have, because of who they are and where they live, are more likely to have underlying medical conditions, and that would actually get them lower ranked in getting respirators in the event that we move to crisis standards of care. And therefore, we actually got the law changed so that our patients would not be discriminated against. Research and dental clinics are now reopening. Like in August, they're going from 30% capacity to 50% capacity in another week. We have adequate but not overwhelming amounts of PPE for our faculty, staff, and students, and that's allowed us to get our fourth-year medical students and third-year PAs back in the clinic in June. We certainly want to get on with their education. The dental residents started in July, and the MD3s will be going back in the clinic along with the PA2s in the beginning of August. So hopefully we will get them back into the clinic where they absolutely have to be. I'm going to let Dr. Polk tell you about more of what was happening, but all through this, we were having demonstrations on campus and off. Our Black students particularly spoke of emotional fatigue. There's a meeting every Monday night with all the US deans, and the other deans were talking about similar reports. So our Office of Student Affairs and the Diversity and Inclusion Office had weekly town halls for our students, and were supported by psychiatry faculty of color. And John will be telling you more about that. So here's kind of the management stages as we see them. We've gotten through the emergency response. That was March and April. We managed to get all of those steps taken care of. Some of our people were here nights and weekends. Rebound is May to July. That's what we just got through. The students are re-entering the clinic. We're incrementally ramping up research as safely as we can. We're going from 30% to 50%. And putting the safeguards in place. The facilities people have been very busy putting up signs, making one-way stairs, and putting up sneeze guards and things like that. We're about to start the rebuilding part. Welcome to the new world, and welcome to our new students. We want to make sure that we have financial stability, and I'll say something more about that in a minute. Facilitate new research initiatives. As I told you, we're really going gangbusters research-wise, particularly with COVID, as is appropriate, and we'll begin testing. And then in November, we might actually, if we don't have surge 2, be able to reimagine and actually figure out which of the silver linings we want to keep. Hybrid classes will almost certainly continue, and we've invested a lot in streaming equipment so that we can do them online or in person. Telemedicine, I think, is here to stay. The patients really like not having to drive in and see their doctor in many cases. And new healthcare policies, I think, will be put into place based on what we've learned specifically about who has taken the brunt of this epidemic. And I think that we've seen a shift in the opinions and education of Americans in how we're going to manage healthcare going forward, to be fair. So we have our new students and our M2s back next Monday. We have in-class and online teaching. Students can decide which they want. They do have to get tested if they want to be in class, and I'll talk about that in a second. The cafeteria is opening August 15th. We can't actually figure out how you can eat with your mask on. Right now, we're trying to send them outside. We have building and elevator restrictions, so this won't be the same old medical center that they left. We've got the saga of the Talbot Green tables. First, people wouldn't socially distance, so they were taking the tables and chairs away. And then the ID guy said, hey, wait a second, that's the safest place to be on campus. So we put them all back, and we try to get the people out there to be having their discussions, and particularly for eating. We have 900 master's students and PhD students coming back September 3rd. So we definitely want to be managing the testing for these groups as they come back on campus. So Doug McDonald asked you about testing. The university is planning on doing PCR testing, anterior nares, for students, staff, and teachers starting last week. We've got the pilot. We're like day 4 of the pilot. This is the area that was set up right before we had people going through it. Here are people standing in line, not close enough, and one doesn't have his mask on. So they're supposed to be checking in. They are handed their anterior nasal swab, which I'm told is very soft. And then they are watched while they use it by people who have been trained to do this. And then the swab goes back in, it gets picked up about 4 o'clock in the afternoon, and it goes over to the other campus, and we have the results back within 24 hours. Not me, the university decided to stand this up in our own labs because basically even the Broad Institute or Quest would have been much more expensive. You can see the differences in the prices here. Even so, this is going to cost the medical school for our staff, students, and faculty about $1 million this semester. That means that if we have to do it in the spring semester, it'll be another $1 million for testing at this level. The turnaround time is terrific. With Quest, I hear that it's now more than a week. But we are limited to lab capacity. I think that the university is figuring they're going to do 30,000 tests a week or more. They have put all of the students, faculty, and staff into 4 categories, and you will be tested depending on which category you fall in. A student in a dorm, as like an undergraduate student or even in our medical student residence, will be tested every 3 to 7 days, and one of the people in their group will be tested every day. And then category 2 is people who are on the public transportation, but don't have a whole lot of interaction with the residential population. And category 3 are people who are less in contact with students and other employees. And category 4 are people who aren't on campus and will not be tested. So everybody's been divided up, and you can switch categories. The AAMC did a survey of medical school deans' top concerns. For me, facing all of this starting like next week, it's keeping everybody as safe as possible. The models say that we are going to have cases. We're going to have 100 cases or more. And we know that this is going to happen, and therefore we have to try to keep the population as safe as is possible. But the other deans and certainly we're worried about financial sustainability. We took a cut. We're now taking about a 5% cut. We have plans for a 10 and 15% cut if we have to of our budgets. A lot depends on how many students will be coming back and matriculating in September. So we're watching that carefully. On the other campus, they almost certainly will have major issues because 20% of their students are international. The deans are concerned about disruptions to the curriculum, healthcare disparities, and population health with COVID, absolutely a concern. Mental health of everybody, and restarting and regaining momentum, although we're doing that with the research enterprise and getting the students to residency, despite the fact that they've had this interruption in their clinical training. And then just basically recruiting and retaining people. Last slide, finances. The research salaries, the NIH has been good to us. It's part of the stimulus, and they've continued to support the researchers, even those who haven't been able to do their research. Foundation and industry support has been mixed, but by and large, they're pretty much supporting, foundations are supporting, industry has deliverables and has been less supportive, and I can understand that. Hiring freeze for non-grant funded staff. So far, the university has not frozen hiring for faculty. All renovation plans are on hold until we find out what our financial situation will be. We lost a lot of rent in the medical student residence, but it also, once we kind of closed it up, it wasn't as expensive to run. So we do have students moving in Friday, Saturday, Sunday this weekend. We expect a greater need for support for student aid because their parents may have been lost their jobs. The COVID and PPE are already expensive. And the question is, we'll have the same tuition income, and BU has a bigger problem. So I really value any of your advice and questions to the extent that you've been through this at your own institution. I'd love to hear your thoughts. and advice or questions, but I think that we ought to hear from John first and then take the questions together. Would that be okay?
Sounds like a plan, Dr. Antman. So thank you for those remarks. Feel free to submit your questions anytime in the chat box, and after we hear from Dr. Polk, we'll go through and answer your questions. So I will now turn the screen over to Dr. John Polk, our Associate Dean for Diversity and Inclusion. Dr. Polk.
I had to unmute myself. Thank you, Suzanne. It's always a pleasure to, and an honor to speak to the Dean's Advisory Board and members of the Chief Society. I see a lot of familiar faces. I was a member of this group for 10 years, and for some reason I was kicked off. Be that as it may.
Dr. Polk, I'm just going to introduce, because we just see your photograph, not your face. So you're going to want to turn on your video. There you go. Perfect. Thank you.
Okay.
Just look back, John.
Maybe I'm not technically challenged. I'm technically challenged and can't do this. Can you hear me?
Yes.
Good. So I was a member of this group for 10 years, and I'm keenly aware of the value that you bring to the School of Medicine. We both, as the Dean just suggested, we value your advice and your insight. For example, with your help, we were able to develop and operationalize the Professionalism Resource Service. That's a service that was focused on professional instruction, support of individuals and departments around professionalism, and ensuring that professionalism was a core part of each and every initiative that we undertook at the medical school. And for that, we're grateful to Simon Apprecier and Leslie Serchuk, who are both members of the DAB. I'm here today to tell you a story which will remind you of who we are as a school and how we view our role as a school during these volatile, uncertain, complex, and ambiguous times. I'd also like to describe how we operationalize that vision in an effort to getting us closer to where we hope to be. We have a long and storied history of our commitment to diversity and inclusion. It's in our mission, it's in our bylaws, and it's in our strategic plan. It's also documented in our history. We celebrate the legacy of Dr. Rebecca Crumpler, 1864, and we led a regional initiative with the help of Dr. McLeod to put a headstone on her gravesite. We're dedicating the 13th scholarship specifically targeting women and underrepresented minorities in her name that Dr. Sullivan has so generously supported. We acknowledge the contributions of Dr. Solomon Carter Fuller, 1897, and the contributions he made to the study of Alzheimer's disease. He actually went to Europe and studied with Alzheimer's and published one of the first papers in the American literature on Alzheimer's disease. And our own Lou Sullivan, class of '59, who served as the 17th U.S. Secretary of Health and Human Services, the founding dean of the Morehouse School of Medicine. But equally important, he was a senior author on the Sullivan Commission report in 2004, missing persons, minority in the healthcare professions, and we're still battling with that challenge today. But I remember Dr. Sullivan as the person who recruited me to medical school, for good or for bad. His role in, his research role in looking at folate deficiencies in undernourished individuals, particularly alcoholics. And by the way, the label that you see on the food in your pantry and your refrigerators are all a result of work that Dr. Sullivan did. And he has a very interesting story about how he got that done in the face of all the lobbying around food and the lack of food security, protection and security. We were one of the first medical schools to actively recruit medical students of color back in the late 60s. And as I said, I was part of that, the first or second cohort. We have the oldest pipeline program in the country, and it's a model for other schools around the nation. It has served as a model. This program is 38 years old. It's the Early Medical School Selection Program. It's a program in which we have partnerships with 10 historical Black colleges in the South and the Southeast, 2 Hispanic serving institutions in Texas, And as Dr. Antman alluded to earlier, we have a school in Hawaii that serves Native Hawaiians and Pacific Islanders. It's probably the first of its kind. And last but not least, our own Bob Witzberg, the class of '76, was a prime mover at the AAMC to develop this whole concept of holistic admissions to medical school as a way to eliminate some of the barriers that we had for diversifying medical schools across the country. So today we find ourselves as a school and a country at an inflection point, a point of social awareness which is focused on the lack of societal equity and social justice. As I read the tea leaves, and as Dr. Sullivan commented on earlier, prior to the meeting beginning, I think this is a result of three intersecting phenomena. We have a polarized political climate characterized but not caused by the divisiveness of Trumpism. We have this disproportionate impact of the novel coronavirus effect on communities of color, particularly the Black community, as well as the xenophobia addressed at our Asian colleagues as a result of this. COVID has really amplified the healthcare disparities in this country, and it was really brought to our attention early on by the Institute of Medicine and the Sullivan Commission report in 2002 and 2004, respectively. And the last thing is the third leg of the stool is the campaign to make Black Lives Matter in the wake of a series of police killings, culminating in that video recording that we all saw of the death of George Floyd, which we cannot erase from our memory, literally at the hands of the police. So during these times, our students, staff, and faculty have asked us and expect us to do more. So some of the things that we are doing is we have a vertical integration group in the medical education office to look at our entire curriculum for the impact of race, racism, but more importantly, anti-racist policies and behaviors within that curriculum. It reported out this June, and it's being presented at the AAMC national meeting at the plenary session in November. As the dean has said, we've had a number of town hall meetings with our students. Our students have formed committees along with our faculty to review all of our primary offices, admissions, student affairs, medical education, and financial affairs to ensure that we have addressed equity for all our students and faculty. 3 years ago, the university, as a result of some work that Jonathan Wilson did a number of years ago, created a position of at the provost level position that's currently held by Crystal Williams. She's the inaugural associate dean of provost for the entire university. And the value of this is that we will have, in the very near future, universal policies and practices with regard to diversity, equity, and inclusion across all of Boston University. And finally, more recently, the university recruited Dr. Ibrahim Kendi to develop the Boston University Center for Anti-Racial Research. Simultaneously, we recruited his wife, Dr. Siddiqui Kendi, to be our new chief of pediatric emergency medicine. The center received a $1.5 million grant from the Vertex Foundation to start this work. And for this support, we express our gratitude to Dr. Reshma Kawal-Ramani, BU class of '98 and a DAD member. So I'm honored to be the new Associate Dean of Diversity and Inclusion at the School of Medicine, particularly at this critical point in our history. This turns out to be my 1-year anniversary, and I really don't want to see my evaluation at this point. I'd like to hold off for another 6 months. I came to this position having spent 10 years on this board and 12 years as an assistant dean in the Office of Student Affairs. In that position, I work with students, staff, and faculty across the campus in an effort to enrich the learning environment. I came to DOI, to the Office of Diversity and Inclusion, with 3 goals. The first one was to continue to promote a rich and robust and psychologically safe learning environment for every person on our campus. The second one was to use our current pipeline programs, and we'll talk about those in a minute, and our faculty development strategies to make BUSM, along with the Graduate Medical Science Department, one of the most diverse schools in the nation. However, in order to accomplish those goals, we need external funding. So that's been a primary goal of our office, is to obtain external funding, and we've been able to do that to a limited extent so far. So the things that we're doing on campus now, as I said earlier, we're holding town hall meetings with the entire campus to discuss difficult topics. And obviously the topic that we started off with was race, racism, and anti-racist policies. We have learned a tremendous amount from our students. We see this from a perspective, or should I say, they see this as from a perspective that we don't. And it's been very helpful. They've been very thoughtful in their comments. We're holding affinity spaces for our Black students. It was initially, as Dean Edmonds says, guided by Dr. Henderson, who's an assistant dean in the Office of Student Affairs and serves as the chief of psychiatry at Boston Medical Center. We're involved in conversations with Black male faculty members to address this issue of the lack of Black males in medical school and in medicine in general. It's really a tragedy, and Dr. Cato Laurentian of the University of Connecticut has called this an American crisis. And we look forward to collaborating with Dr. Kendi and the Center for Anti-Racial Research in some of the work that he's doing to help us in some of the work that we're doing. Dr. Sullivan's report in 2004 really emphasized diversification of the workforce as a way to address healthcare disparities. And we've taken on the task historically at BU of promoting pipelines, as I said earlier, to careers in the STEMs. We have some robust programs, and we're in the process of getting support for some of those programs. We're working in collaboration with the Graduate Medical Sciences Department, the Boston Public Health Department, and the Boston Public Schools to provide opportunities for high school URMs to gain experience in mentoring, advising, and research experience here at BU. And that program is called BEAMS, Boston Education, Advising, and Mentoring in STEM. We're in conversation with potential partners to support another program that was piloted here at BU, along with 4 other sites across the country, which is called Best Bet. It's broadening experience in scientific training, beginning enhancement track. That's a program where we bring college students from the area into BU, particularly into the labs, and give them hands-on experience in the labs, as well as advising and mentoring. Another program that we have that has quite a bit of legacy to it is the City Lab program. That's a 34-year-old program that offers these similar experiences to high school students. But the uniqueness of this program is we take the resources of the medical center out to the high schools. We're looking to get additional support for that program. And finally, the EMSSP program, the Early Medical School Selection Program, has a new director. The new director is Dr. Ebony Woolcock. She's a graduate of the program. She's a young African-American woman who grew up in Dorchester, who went to Hampton University, who entered the program via Hampton, which is one of our partner schools, and graduated from BU and with an MD and an MPH. Completed her residency in obstetrics and gynecology at Boston Medical Center, and worked for that other medical school in the city for 4 years at BI Deaconess Medical Center, and now she's back with us. So we look forward to her impact on this program. Both BEAMS and the EMSSP program receive grants from the Vertex Foundation to make structural changes in what will only enhance the program. This is critical for the academic advancement of those associated with the program. Our graduate medical education program increased the number of URM resident physicians in training at BMC. And what the Office of Faculty Affairs has done is developed a program to transition some of these residents into junior faculty positions as a strategy to hope to retain some of them as faculty. And finally, with the help of the Dean, we've launched an initiative to utilize the NIH Diversity Supplement Grant. That's a grant that has been around for quite some time. And it's a grant where a established NIH PI can get up to $125,000 a year to support an underrepresented minority if they put them on a separate project, not their own project, and mentor them along in that program with some pretty rigorous reporting. This was a result of some work done by the Mid-Career Faculty Development Program under the leadership of Amelia Benjamin. They literally delivered this to us and says, so what can you do about it? And we've been in conversations with the Dean, and we have a working group which consists of Andrew Taylor, the Associate Dean of Research, Julia Huntsman, the Director of the Office of Proposal Development, where these grants are really developed, and Frederick Maun, the Associate Dean for Research, Administration, and Finance. So we look to this program as a way to get junior faculty out of the ranks of instructor and associate professors and into assistant professors, rather, into the associate professor levels. So in closing, I hope you found this story interesting and insightful. BU has a long and continuous history of not necessarily bending the long moral arc of the universe toward justice, as Dr. King has suggested, but we like to think we're moving a needle on the social justice and equity dashboard. In the words of Dean Antman, we view this as a continuous quality improvement process on our journey, a long and rich journey of diversity, equity, and inclusion, not a box checking exercise. We look forward to keeping you updated during the unending process, but we also look forward to your thoughts and ideas because in the past, you've been extremely helpful to us. Thank you.
Thank you so much, Dr. Polk. And now, oh, now we can see you. There's your video back on. Good, keep it that way. So now we're ready to take any questions. If you'd like, you can enter them in the chat box, or I actually think we're probably a small enough group. If anyone wants to raise their hand and unmute, you can ask a question. Dr. Sullivan.
Well, thank you very much, both to Dean Antman and to Dean Polk for your presentations. Very interesting and very quite a few things going on. I have a number of questions, really, some pertaining to COVID and the others pertaining to operations of the school. My COVID questions are, first, have you been affected by COVID among the students or any of the faculty? Have you had any problems there? And the second has to do, could you comment on any changes in the curriculum other than moving to online instruction? What about things such as physical diagnosis, et cetera? What changes have you had to make there?
Your mute is on, Karen.
Great questions, Lou. We had a medical student in the student residence who, as far as we can tell, got COVID not from the hospital, but from social events. We made the diagnosis, had him tested. He and his roommate both had to quarantine. He recovered very nicely, and the roommate never got it. So that's the only student experience we have that we know of. Certainly once we sent them home, they could have had it at home, but they didn't tell us. With the faculty, it's very interesting. The group that actually took care of the COVID patients, especially the ones in the intensive care unit, actually had a lower rate of being infected than the ones on the general services. And the way we think about this is, first of all, they really cared about the PPE, and many of them actually lived in the basement or actually lived in one of the dorms while they were on service. and therefore they actually were separated from their families. And we think actually that the majority of the cases came from people that got it from social rather than hospital sources. So yeah, we've had a few cases, nothing bad. But it's interesting that the ones who actually were front and center at the front lines were actually had a very, very low rate of seroconversion, lower than the others. Isn't that interesting? Now, obviously for physical exam, we have to have a plan in place that has to be approved and compatible with the state's requirements. So for physical exam, we will be pairing, we have this concept of cohorting the students so that they'll only see a group of about 8 students. So their physical diagnosis classes and the classes that they have in person will all be amongst 8 students. So they have a smaller group of people they're going to get mixed in with. And they will be doing physical exams initially on their roommates. That's a little socially awkward, but it's a lot safer because that's the person you're going to be getting germs from anyway. So the idea is to keep the circle low. They'll have to wear PPE for physical diagnosis, and then they'll be taken over after they are relatively good at it, and they'll be seeing patients in PPE, whatever is appropriate at the time. Right now, it's a surgical mask, a shield for non-COVID patients, and obviously full PPE for COVID patient. Some of the deans across the country are talking that we need to teach our students how to take care of COVID patients. So although we pulled them from the COVID services, they're now being gradually put back onto COVID services, but with adequate PPE and good training. What else would you suggest? Because you've obviously, you knew that this would be the really difficult part. You should see the dentists, how basically the students are in people's mouths. So if we think that physical exam is going to be tricky, their physical exam and doing their work is trickier.
Well, I think it's a real dilemma. That reminds me of one other question I had. Is there anyone doing vaccine research there with the COVID virus there at BU?
A lot of the work is done on screening current compounds for any activity for COVID. I don't know offhand who's working on, okay, Suzanne might.
Well, there is the fund that Suzanne Cutler established on vaccine
But that's not
education and
COVID
research.
vaccine, yeah.
No, they're expanding their research to cover
okay.
COVID.
Good, okay.
And it's Dr. Rebecca Perkins and Dr. Natalie Joseph, one from OBGYN and one from pediatrics. They are extending, and thank you so much to Suzanne Cutler for that support. They're extending their research to look at how COVID will impact the receptivity to vaccinations, whether COVID or otherwise.
You remember that they presented, and at that point they were working on HPV vaccinations, but this is, and well, baby care and that sort of thing. So it's a natural extension.
You know, I think it's been remarkable. We've had this virus hit us, and as you know, there have been something like more than 100 vaccine candidates with the concept that they'll be narrowing down to perhaps less than a dozen, with 3 or 4 possibly being developed. And I think, considering the fact that this virus really appeared perhaps last December in China, the fact that we may have a vaccine by the end of this year, I think is remarkable, but it doesn't help us right now when we're in such difficulty. I think having had 70% of the patients in the hospital being COVID patients, your experience with so few of the faculty becoming infected, I think that's remarkable, because I certainly have colleagues or friends who've developed this infection, one at Maimonides Hospital who died, unfortunately, from this. But my other questions I might ask to John Polk. First of all, some of you may know that when I was on the faculty there back in 1968, following Martin Luther King's assassination, there were about 12 of us faculty who came together to really work to recruit more Black students to the medical school, because at that time, I think there were only 7 black students in the whole school in 1968. We ended up with the New England Recruiting Weekend Thanksgiving of '68 that not only involved the BU Medical School, but we worked with Harvard, Tufts, Brown, UMass, Dartmouth, and Vermont to really try and recruit more black students to New England schools. And it turned out to have some success. I think the following September of 69, I think BU had 6 or 7 first-year students. I think Harvard had 9. And the other schools had significant numbers as well. The only New England school that did not participate, two schools, Connecticut, because by state law, they could not admit out-of-state students at that time. I don't know if it's changed or not. Yale never responded, so we could not really get them involved. But at any rate, just to segue to the issue of minority representation, first of all, let me say I'm very pleased with the scholarship that has been established in Rebecca Lee Trumpler's name. I think it's well-deserved, and I also want to congratulate you on getting the headstones put on her grave. She really deserves that, and I think being the first black female graduate of a medical school in the country, that's remarkable. The questions I have
just a shout out to Dr. Melody McLeod, who actually was key in getting that recognition for Dr. Crumpler. And she's she's right here.
Right. That good work. Good. And of course, you've mentioned Solomon Fuller, the black psychiatrist. We have the Fuller building there. The question I have is, any thoughts as to why we have such difficulty now in terms of black students? It really, having so few black students now is really quite surprising. Is it, how much of that is financial need? Are there other factors there? Are the other things that we might do to try and help that issue? Because as John, as you noted in your remarks, this COVID pandemic has really ripped off the issue so that now people understand in a way that they didn't before the health disparities that exist between the white population and the nation's minority populations, particularly African American and Native American populations. But I'd be interested in what you think might be the reason that we're not doing so well with black students, and what things might be done to change that.
Lou, I think you can answer that question better than I can, but let me give you my answer. Okay. Because you and I have talked about this. You know, what's under our control, I think, is pipelines. I think we need to do everything we can to reach as far back as we can, far early as we can, to get students interested in STEM. I think that's the key. There are a whole other sociological problems that we can't control. And when I drive to work and I think about this question, I come down Molina Cass Boulevard, and all of the black males are in the prison on the left side of the street, and there are no black males in the research labs on the other side of the street. So it's something that's on my mind. But I think I'm going to spend most of my efforts around pipeline, getting young kids in middle school and high school interested in fields in STEM, and to show them that this is a career with legs. It has a bright future. There are other issues, financial and other things, but I think you have to generate the interest to get students, a cohort of students directed this way.
Well, I think some of you have heard me make this comment before. When I graduated from BU in 1958, I owed $500 to the Student Financial Aid Office. That's so different from what happens with students now graduating with $250,000, $300,000. And I wonder how much of this might serve as a disincentive to tell low-income students that medicine is not an option that they should even think about. So I don't know how much of a contribution that issue is making to the paucity of students here.
We now have scholarships that go for need that go up to $30,000. So it's about a half a scholarship. We have a couple of scholarships that are full scholarships, like the Martin Luther King Scholarship. And we very much appreciate your scholarship. I think we have 12, we do have scholarships for Black men. So it was totally appropriate that we would have a scholarship for Black women too. But when we admit Black students, they have, we've asked, the Black students have a choice of 10 schools, that they have been admitted to 10 schools, and the white students have been admitted to about 5 schools. So we have about a 20% chance of getting the white students, but we only have a 10% chance of getting the Black students unless we are better than other places. We don't have as much scholarship aid as Harvard or Yale or that sort of thing, but we certainly provide scholarship aid for the students based on need. The Black students last year, and we check this every year, graduated with about $10,000 less than the white students. The Latinx students graduated with almost $40,000 less. So the 2 underrepresented groups are actually at lower debt than the white students, but I think that they're much less comfortable taking on that debt than the white students. Yes, Suzanne?
Well, I do want to get to one other question that's come through the chat box before we run out of time. And I also want to give a thank you to Dr. Ronald Ragland for his scholarship support at the school for our underrepresented minority students. That's most sincerely appreciated. So Dr. Zhang mentions that at her institution, which is Geisinger, the faculty gave up vacation days and CME benefits, but managed to preserve their salaries. Some of them also donated to a COVID employee emergency fund set up to support staff with financial needs. Upon reopening, they're committed to working 15% more, including Saturday clinic hours. In the case of a second surge in Boston, is there a plan for how the faculty can potentially contribute to the continued success of BUSM?
I think that it'll be just like the last time, that all hands on deck, and the first priority is taking care of our patients. Financially, the senior leadership took about a 10 to 20% cut, depending on how senior they were. The faculty so far have not taken a cut in salary. We basically, the 5% cut in budgets was achieved by taking away the travel and food money, because nobody's traveling and nobody's eating on campus. You know, all the social events and things like that, and gathering back the unfilled positions because we have the hiring freeze. So the 5% cut was relatively painless to the faculty and the staff, but certainly a 10% cut if we don't have the tuition incomes in September that we think we're going to have, or a 15% cut would be really, really painful. But we think that financially we're okay. I hope you got that picture. But yes, I think that the faculty, you know, they really are heroes. They were working, they just did the right thing. And fortunately, we got through the COVID situation. We now have, unfortunately, continuing cases.
Dr. Fontella Bryant was just recognized by U.S. News and World Report as a hero. I think one of 50 heroes across the country. She's an emergency room physician and an assistant dean in the Office of Student Affairs.
And a great role model for our students.
So we are
American.
We are at the top of the hour. Does anyone have any last questions? Or our speakers, any last comments?
It's just great to see everybody. It's nice to see your pictures, even if we can't actually say hello. I know that we're in email contact with many of you, and but it's really nice to see your face.
I see Dr. Ragland has raised his hand. Go ahead and unmute and ask your question.
Do you have a question, Ron?
Oh, you're just saying hello? If you unmute, we can hear you.
I can unmute you.
There you go.
I just wanted to say hello I live, this office here is about a mile north of where so much of the bile has come forth from the executive branch. And I think that people of goodwill recognize that it's strategically planned and it's highly injurious. I think that there's a temptation um, to have a knee-jerk response and to give bile for bile. And that's something that would be um, would further inflame the situation. So as hurtful as it is, those of us that have good sense and goodwill must act with sobriety, in my opinion.
And thank you for supporting our students' scholarships. We really appreciate, they really appreciate it.
This is Dr. McLeod. Let me know when I can come in. Can you hear me?
Oh, Dr. McLeod, sure. Go
Hi,
ahead.
I hope everybody's doing well. I'm going to keep my picture up because I just washed my hair before I sat down for this, so nobody needs to see all that right now. I just, again, thank you for the mention about Dr. Rebecca Lee Crumpler, and I just hope everybody saw the NBC Nightly News segment that aired on Sunday the 19th, and also the Boston Globe article that ran on the 17th. If you didn't, we can get that to you. In reply to something that Lou said about, I guess, you know, Blacks getting into medical school, to me, I just think it's an issue, you know, before kids even get to medical school to deal with whatever debt they're going to be encountering, they have to have an interest to do so. And I really think that's one of the issues that the Black community and parenting needs to address, because we need to make sure kids are geared to other things other than sports and music. You know, there are science camps, there are ways that kids can get exposed to these other things. And unless parents engage their kids, make use of community services, have role models, and we need, especially for Black men, we need Black men out there who are doctors to you know, show themselves and to get out in the schools, maybe do some, you know, visit high schools or even grammar schools and get on out there in the community. In fact, since the NBC segment aired, I've gotten some emails from, you know, people, you know, from all over, young people, young girls who like, wow, I just, you know, wow, you know, just to even see those 3 students, and thank you for getting those students. I thought they did an excellent job. But we just need to show more that there are Black doctors out there and Black people who are adults. Of course, my phone's going off right now. I don't know who that is. And I just want a new phone, so I don't know how to turn it off. Okay. Anyway, my point is we need parents to, you know, we need intact we need more Black family structure, and we need them to be guiding their kids to things other than sports and being hip hop stars. That's all I have to say.
We have this program with Boston Public Schools. It's 80 students every summer. The medical students actually get paid to basically do teaching in small groups, and they're doing it by Zoom this year. But last year they sliced up brains. We took them to the OR. We basically had them do poster sessions on neuroscience and things like that. So we have these programs for the high school students. The idea is to get them into BU, where if they graduate from Boston Public Schools, they will get a full needs scholarship, and then to get them back to the medical school.
I think
so we follow them. Once they're over there, we literally follow them and hope that they'll come back. And it's okay if they go to a different medical school.
One thing that was instrumental for me, and really I think one of the key things that gave me encouragement to become a physician and the desire, is that when I was a little girl, actually had a Black female pediatrician at the time, which was back in the 60s. Okay, Dr. Doris Weathers, and she was in New York City, and she was a sickle cell pioneer woman. She died last year. So I saw her, you know, and I remember I told Kate Snow this. I remember in high school at a PTA meeting, I was there with my mother, and I remember my high school history teacher told my mother, make sure she takes typing because Black people don't become doctors. Okay. And I remember, I still vividly remember that, and I still feel that. I can see her, and I still feel that comment from her. But I knew better because I had Dr. Weathers. Okay, I already had I had a Black doctor. So again, we just need to have more representation and exposure of these young kids to things other than just sports and ball. So I'm glad to hear that you're doing that with the public schools there. Thank you.
Thank you.
Well,
Thank
I'd like to thank the Dean's Advisory Board. Again, I think you are critical to the success of initiatives that we take at the School of Medicine. So we really value your input. I see Lee and Shami, so thank you.
And you'll think about this and you'll have an idea, and please send us emails with advice or things that you're doing it wherever you are that we could be doing too. Other good advice. It'd be terrific. Okay?
Thank you, everyone. Thank you to all our supporters. And if we didn't get to your question, as John and Karen said, just reach out to any one of us.
Thank you.
Have a good evening.
Stay safe.